Hello, my name is Cesar Fukuda. I'm a pulmonologist from São Paulo, Brazil, and my specialty is on interstitial lung disease. We had a case of a male patient, aged 54 years old, was never a smoker and had no comorbidities, but was going through a stressful time. This is the timeline of the disease. On day one, it was made a diagnostic with fever and cough. Then on day six, he was admitted to ICU. On day 15, intubated. On day 20, extubated. And 34 days after the admission, he was discharged from the hospital. Initially, the patient presented with mild tachypnea and dry cough, so nasal cannula was placed as an oxygen support. Then, as the hypoxemia worsened, it required a non-rebreather mask, followed by a high-flow nasal cannula, and finally, an intubation was necessary. Uh, these are the laboratory tests. The white blood cells and lymphocytes were between the normal range. Some inflammatory markers were elevated, like ferritin PCR, D-dimer, LD8, and interleukin-6. And procalcitonin and REN kinase function were normal. This CT scan showed some bilateral ground glass opacities and some focal areas of consolidation. The treatment was done with dexamethasone 10 milligrams once a day, and fractionated heparin, physiotherapy, non-invasive ventilation, and no antibiotics were used as there was no clear evidence of a bacterial infection. Photobiomodulation was started on day 15 after intubation. On June 19, PCR reached the highest value, and coincidentally with the initiation of photobiomodulation, it started a gradual decline. How was laser used in this case of COVID-19? It was used a transthoracic laser and also a transdermal laser irradiation of the blood at carotid artery. Transdermal laser irradiation of the blood at the carotid artery. So it was done a perpendicular cluster position with the object of a systemic effect for during 10 minutes and a frequency of twice a day. Uh, it was used a red laser of 660 nanometers, power of 100 milliwatts, and an energy of 60 joules. And why irradiate the carotid artery? Because the risk at ICU was with catheters. It could lead to a reduced time of application. And also there was a complication at the neck area that was a subcutaneous emphysema. This study evaluated the adjunctive photobiomodulation for COVID-19 10 patients were included, all of them on oxygen support, but not intubated. The patients on photobiomodulatory showed a faster recovery, no need for ICU or mechanical ventilation, and had no sequelae after 5 months. The transthoracic laser irradiated the lung. The cluster was perpendicular with the objective of anti-inflammatory local effect. The duration of 16 minutes and a frequency of 2 times a day. This was the equipment used, was a Sumus laser class 4, model P4, with different wavelengths and frequencies. This is how we made the photobiomodulation. We divided the area in 4 sections. Each section received 4 minutes of irradiation with total energy of around 1,500 joules per section. This is a photo when I was irradiating the patient at the ICU. And in this is a systematic review with 17 papers on animal models, where photobiomodulation reduced pulmonary edema, neutrophil influx, and generation of pro-inflammatory cytokines. In this CT scan, we can see an extensive lung involvement with ground glass opacity and also some areas of consolidations. That was complicated with also pneumothorax and pneumomediastinum of the lungs and in subcutaneous emphysema that had to be drained. This is the recovering process where we can see some residual ground glass opacities and some interstitial thickening of the lung. As final messages, photobiomodulation may be a helpful adjunctive treatment in the management of COVID-19 disease, and this case may have helped to shorten the period of intubation. COVID-19 leads to a systemic inflammatory response syndrome and also increase the risk of pulmonary fibrosis. And some randomized clinical trials should be carried out on the photobiomodulation effects for the COVID-19 disease. Thank you for your attention.